All right. Good evening, everyone. Welcome to the next session of Virtual Global Spine. I am super, super pleased and honored to have my good friend, my colleague, my partner, my mentor, my former chief resident, Dr.
Wow.
Soriaya Motivala. Oh, and Dr. Galad in the background. Dr. Motivala is a dear, dear friend and colleague of mine. She is the head of neuromodulation and spinal cord stimulation at Spinal University Hospital, and she's basically one of the top experts in the field. Today, she's going to be talking about neuromodulation for chronic pain.
Hi, everyone. I wanted to make thank you for having me. Thank you so much. I wanted to make a very sort of informal discussion about sort of where we started in this space and where we are now and how it might be of help to you in your practice as an adjunct. And I know there is a wide variety of experiences people in spine surgery have with neuromodulation for chronic pain. For a lot of orthopedic spine surgeons, by the time they finish their residency and fellowship, they may have seen one spinal cord stimulator, and it was usually the one they took out to do a T10 to pelvis because it didn't work. And that's sort of been the paradigm for many, many years. For neurosurgical spine colleagues, they may have a little more experience, though a lot of academic programs still very much focus more on the deep brain side of neuromodulation and less of the chronic pain side. So I just wanted to give sort of general talk about some cases, and we can have a good discussion. Feel free to interrupt me at any point. Disclosure, I'm an educational consultant for Abbott and for Medtronic in the STIM space. And so let's talk a little bit about chronic pain. Chronic pain is a huge, growing, and a very expensive problem, not just in this country, but globally. Costs in this country probably exceed about 100 billion annually, and they're growing. There's about 515 million workdays that are lost because of chronic pain, people calling out sick, 40 million doctor visits annually, and about 22 million patients roughly with back and neck pain that some of us we see, and some are just out there seeing other providers. So I wanted to talk a little bit about the history and evolution of spinal cord stimulation. Very interestingly, electrical stimulation has been used to treat pain across many cultures for actually thousands of years. And this is a rendering from about 9000 BC, where we see they were using electrical fish, ray fish, to treat headaches and arthritis. You can see it's pretty rudimentary. I would say these are the first spinal cord stimulators, if you were. So we had this idea that you could treat chronic pain with electrical stimulation far before we had any understanding of the human nervous system. John Wesley, one of the founders of Methodism in this country, extolled the virtues of electricity for the treatment of chronic pain. In one of his books, he talked about electrotherapy for cardiac angina, for gout, for headaches, for pleuritic pain, and for sciatica. And that brought us all the way up into 1965, when two gentlemen from McGill, Meldick and Walls, sort of espoused or came to the conclusion of their gate control theory of pain. And that's sort of the founding principle of the chronic pain space. Now, we have evolved since then, and not all of this may hold true, but it was the first thought process that, sort of codified thought process where we thought, well, central inhibition of pain by a non-painful stimulus would reduce pain. And this is this idea of counter stimulation or counter irritation. And the idea was that you had these, C fibers, these, painful, noxious C fibers, sending from the knee or other parts of the body, that then project these neurons to the dorsal horn, the pain gate. And those then go up to the sensory cortex, and that's how you feel pain. Well, if you stimulate these A beta fibers, which are sort of that dull sort of sensation, more of the pressure sensation, non-painful signals like a TENS unit, that would stimulate the inhibitory interneurons, and they would close the gate, and you would not get those signals going up to the cortex, and therefore you would not feel pain. That's sort of the main basic of this theory, and that's kind of how the entire beginnings of neuromodulation for chronic pain sort of went scientifically. So these lovely two gentlemen, in order to prove their theories, actually experimented on themselves. They, stimulated their infraorbital nerve, their various peripheral nerves, ulnar nerves, using needle stimulating electrodes to sort of kind of get a good idea of how this would work. Once they felt that this would be safe to do, they then proceeded on other human subjects. So you could see we had very different research protocols back then. This led to a collaboration with a gentleman named Dr. Norman Sheely. He was a neurosurgeon in Wisconsin. And he and his colleagues sat there and they pontificated that that neural gate would be closed by stimulating the dorsal column. And he initially confirmed this assumption in cats. And by 1967, he implanted the first dorsal column neurostimulator in a 50-year-old woman suffering from intractable pelvic pain from metastatic disease. And I'm going to show you, and that initial implant then led to a case series that was published in the Journal of Neurosurgery in 1970, looking at 6 patients they implanted for chronic pain with the first ever real dorsal column stimulators. And they looked at 3 cancer patients, a patient with a chronic intractable severe L5S1 radic after discitis, multiple sclerosis patient with painful paraplegias and spasms, and a patient who developed a kind of a very painful cauda equina type syndrome after a misplaced Harrington rod during surgery. So really, I would say that patient was the first failed back patient to ever be implanted with a dorsal column stimulator. And these implants were pretty rudimentary. There were square platinum plate electrodes, and they were placing them about 4 to 8 segments above the pain input, which really hasn't changed much when we talk about dorsal column stimulation. And these electrodes consisted of these platinum plates with bipolar stimulation. They were attached to a silicone impregnated Dacron sheath. And at this time, they actually sutured it directly to the dura. They then had an implanted radio receiver, and there was an external battery that transmitted to the RF device that you had to sort of wear attached to yourself on a belt, quite cumbersome. And these were the original dorsal column stimulators. And you can see here, this is some imaging, X-ray imaging of one of the first dorsal column stimulator. It's a pretty small paddle. You see this huge radio frequency receiver that's pretty much the size of the entire generator that we have now that was implanted in the patient. And then they had this amazing battery box they had to carry around with them with the kind of the charger, if you will, or the antenna that sort of had to stick to their back. So they were very uncomfortable. They were very cumbersome, but they worked for some patients and they had pretty good results. This sort of work led to these finally being FDA approved. So by 1977, physicians, surgeons were kind of implanting these devices off-label kind of in droves. Neuromodulation devices, not just for chronic pain, but for epilepsy, for deep brain stimulators. And they decided they had to get control of this, and they had a meeting. And they looked at stimulators for all of these problems, for pain, for movement disorders, for epilepsy, for cerebral palsy, for bladder control. And they were looking at all of this because there was a whole rush of getting these implanted into patients. And at that time in the 70s, they really only felt like we had good data for pain. And so they only approved these at that time for neuropathic pain of the trunk and limbs. And the FDA approval came through in 1980. In 1981, Medtronic developed the first fully implantable SCS device. So we went from 67, where you had to carry an external battery around with you, to everything being implanted in the human body. And from there, what we've seen is just an explosion in this technology, an explosion in the usage of these devices for chronic pain. They now represent 70% of all neuromodulation cases that we do. And around 34,000 patients are implanted annually worldwide and growing. Since its development, the technology has evolved significantly. Over years, initially, it was just sort of what we call like the widgets changed. You know, you would make a more extensive paddle. Instead of 2 rows of contacts, someone would come out with 3. Instead of a 8 contact electrode, you would have 16. The batteries got smaller. We went from just primary cell, which has to be changed in 3 to 4 years, but the patient doesn't have to interact with it and recharge it, to these rechargeable batteries, where the patient does have to interact, but they can be used for a good 8 to 10 years. The devices, a lot of them have become MRI compatible. The type of stimulation we could do changed with Nevro introducing high frequency stimulation. It's the first time we could stimulate the dorsal column and have the patient not feel paresthesias. All the devices before that, you had to feel the tingling, and some patients found that irritating, and then the device was just not appropriate for them. As well as more recently through Abbott, DRG stimulation and their burst stimulation platform, which is a dorsal column platform, where actually the electrophysiologist and the doctor actually patented the waveform. So he owns that physiological waveform. It mimics the physiological firing of neurons in the brain. So all he did was look at nature and then patent it. And they're having excellent results with that. We also, the devices have become highly personalized. We can do multimodality programming. We have new, ways that the information from the battery as to how the patient's doing as far as their sleep, their activity, their movement can be uploaded into the cloud and analyzed. Really, it's taking off. So there are commonly accepted indications. Primarily, the biggest indication we all see in our practice is failed back surgery syndrome. That is probably the number one, followed by complex regional pain syndrome. But then we are also seeing it for intercostal neuralgia, post-herpetic neuralgia, occipital neuralgia, chronic axial neck pain, chronic pelvic pain. We see it for post-pain of spinal cord injury patients, multiple sclerosis. All of these things, it's exploded in the space. Female chronic pelvic pain is a new one that we're having a lot of success with. But there are some contraindications. There are absolute contraindications to implanting this device. If a patient has a current infection, and that goes for any surgery, obviously you're not going to implant the device. If the patient is significantly mentally ill, I would not recommend implanting the device. If the patient has other physical impediments to interacting with the device, disabilities where they wouldn't be able to use it properly, you would want to rethink that. People with a lot of secondary gain. There is a lot of secondary gain, especially in anyone who takes care of workers' compensation patients, patients who have lawsuits pending, to have these devices implanted just so they can claim they've had surgery and then promptly have them removed when their case gets settled. And so you have to filter that out. The other thing is, it's not really appropriate if the patient has a significant structural lesion that needs to be addressed by surgery, and that lesion is causing a neurodeficit. You would want to avoid that. So a little bit of that. Now, let's talk a little bit about failed back surgery syndrome, which I know is the bane of all of our existences and a terrible term for what is really just, I am displeased with the outcome of my surgery. A friend of mine likes to say, I did a damn fine operation, a DFO, and they still have pain. And we see that constantly. You get images, everything looks great, they're still having back and leg pain. And so it's this persistent pain after spine surgery where the spine surgery was intended to relieve those complaints. It's a dissatisfaction. The literature quotes anywhere from 10 to 40% of spine surgeries. It's about a $20 billion annual direct healthcare cost in this country. And it is the 5th most common reason for MD visits when they pull all the codes. It is very, very important when you are considering a patient who you consider failed prior to sending them for a neuromodulation trial to rule out any continued structural causes for that pain. Recurrent disc herniations, foraminal stenosis, a pseudoarthrosis, hardware failure. Is the pain facetogenic? Do they need to be fused? Is it SI joint pain? You also want to sort of filter out for associated psychological disorders. Is this a patient who has untreated anxiety and depression? It's a little complicated in chronic pain patients. It's always a little bit of horse before the cart, cart before the horse. Do they have chronic pain and now they're anxious and depressed, or is this all part of their anxiety and depression syndrome? And then you need to be very, very careful about these secondary gain patients, which sometimes it is hard to tell. So I wanted to talk about a couple cases and things that have come my way, things that I think are appropriate to be sent for a trial of a spinal cord stimulator before an implant, and things that are wholly inappropriate for that sort of algorithm. So this was a patient that I saw in my practice, 45-year-old female. She had a percutaneous L5-S1 microdiscectomy done by another proceduralist, and she had continued refractory S1 type radiculopathy right down the leg. After the procedure, if you ask her, maybe she got better for a couple weeks, maybe a month, then the pain was right back and over time had worsened. She had almost a year of conservative management, and true to form, some of it was she kept bouncing between pain management doctors looking for someone to fix the pain. Multiple epidural steroid injections, medications, physical therapy. Ultimately, she ended up seeing a PMNR, or pain management doctor, and that doctor trialed her with a stimulator. And the patient came and had about 50% relief of leg pain. And in order to be considered a candidate for implant, you have to have 50% or more pain relief with your trial. The trial lasts anywhere from 5 to 7 days. The other thing you want to be careful of, if a patient ever says, oh, I had 100% relief with my trial, those make me worry the most. Those are the people who will never be satisfied with their implant. Never. They are looking for something that is not possible. So this patient was sent to me after her trial, considered successful by the metrics for getting it approved to implant the patient. But she didn't have an MRI in the last year where she's complaining of worsening and worsening pain. I obtained a new MRI, and any patient who is getting implanted with a spinal cord stimulator, if it's percutaneous, you at least need an updated MRI assessing the low back and legs, so the lumbar spine. If you are implanting a paddle stimulator as a surgeon, you really need to have a thoracic MRI. You do not want to get stuck in a situation where you do a laminectomy, place an epidural paddle, which does have mass effect, in a thoracic cord situation where there's severe stenosis and you end up with a horrible neurologic complication. It would be indefensible. So I do not recommend you do that. For percutaneous electrodes, it's okay. You don't have to have the thoracic MRI. It is not considered standard of care. So in this patient, she's complaining of radicular pain, unilateral radicular pain. I got a new lumbar MRI, and this is what I found. Huge right-sided L5S1 disc herniation, concordant with her pain. This is not a patient who should have a spinal cord stimulator implanted. This is not a patient who probably should have been trialed, because what she needed was a discectomy, a true discectomy, which she had, and her radicular pain has completely resolved without having to have an implantable device. So again, you are assuming sometimes a patient comes to you, they come from a colleague, someone you feel like they've been all worked up and this would be the right thing, but you really, even with your own patients, before you send them, make sure you have updated imaging, make sure you're confident that there isn't a structural problem that you need to be fixed that can address their pain syndrome. This is another case that we performed recently. This is a 77-year-old female. She passed medical history, aneurysmal subarachnoid hemorrhage, had an aneurysm clipping years ago, did okay from that. Coronary artery disease, osteoporosis, but more significantly, since the time of her previous lumbar fusion, and she had an L2 to 5 decompression, pedicle screw instrumentation, posterior lateral fusion. It's about 5 years ago. She's had a lot of decline with her Parkinson's. She has severe axial back pain. She does have some leg pain. It's not as bad. She's failed physical therapy, medications, injections. She's got a little bit of this, proximal junctional kyphosis. If I was able to, upload all her CT images, you would see she really didn't fuse. The hardware's in place, but she really has no fusion mass to speak of. And so she's got a pseudoarthrosis. And so, some people would say, okay, let's go fix the structural problem. But you have to look at the patient. This lady was frail. She is got some dysphagia from her Parkinson's. To put her through a huge surgery, it's taxing. There's a high, morbidity, mortality rate, long surgeries. They're not taking their Parkinson's medication. By the time they go to be extubated, they can't because they're off their meds and they're in this off state, totally rigid, not responding. These are really difficult patients to take care of at this point. And so we elected instead to send her for a trial of a spinal cord stimulator. And she had really good relief of her back and her leg pain. So we did a percutaneous implant for her. She was able to go home the next day. We kept her one day just to watch her because she's not the most medically well. And she did great. She was up and walking around with PT, feeling great. It's been 6 months. She has absolutely good reduction in pain. She is happy. She feels like she's got enough of her life back. She's able to travel. She's going to Greece to see her sister, who's quite elderly as well. She's had significant dose reduction of her opioids and all the things that come with being on high dose opioids, constipation in elderly people, drowsiness, they're at risk of falls. So, this is a case where you can do more, but sometimes doing less is better for the patient. This is another case that got sent to me from a colleague, and these things, they can happen to all of us. So this is a 57-year-old male, morbidly obese, hypertension, diabetes, and he had this, L5S1, sorry, not TLIF. He just had a posterior L5S1, posterior lateral fusion, laminectomy for back pain. After his procedure, he developed intractable left lower extremity pain. And I don't, as somebody else did his surgery, I don't have the pre-op images, but he had absolutely failed conservative management. So he went into the surgery with just back pain, and he ended up leaving the surgery with severe back pain, horrific pain down the leg. Mostly it was the lower extremity radiating pain, and walking with the cane, which he didn't have before. He got multiple opinions, including from another surgeon that said he needed a revision of his fusion, and ultimately decided to have a trial of a stimulator. And he's nice and fused, hardware is there, everything's decompressed. There's really nothing surgically to do here, and he's in pain. So we did the trial. He got a trial of a stimulator. He had 70% relief of his left lower extremity pain. We put in his implant, and he's doing great. He doesn't use a cane anymore. The first weekend after his implant, he told me he was able to go to the Antique Roadshow. I guess that's his jam. And he walked for 4 hours, and he bought his wife a necklace. And he felt really good about himself because he had basically been sitting on the sofa immobile for a couple of years. And so when there's no other structural surgery to do and your patient is having intractable neuropathic pain, this really, really can be a life-changing procedure for them. Not for everybody, as we know, but for some patients, it's really, truly a blessing. And then another patient where I think, we always can do big surgeries. It's always possible. I know you guys are preeminent spine surgeons. I know you can correct this, but the question is, should you, right? 75-year-old lady, severe osteoporosis, coronary artery disease, has stents, on aspirin, on Plavix, COPD, on HOMO2, chronic debilitating axial back pain. Use a walker, deconditioned, sits most of the day, has failed all conservative management. I mean, this would be, probably a very large surgery. It would be a T10 to the pelvis kind of surgery, or multiple lateral surgeries. This is not really a patient who's going to do well with that. And so what I proposition is, in these patients, it is probably reasonable to do a stimulator trial. Look, if they fail it, you haven't lost anything. You can always go back and offer another surgery, but maybe you give them an opportunity to have enough pain reduction to live comfortably in sort of the way that they are living, that they don't have to go through all of that and all the risks of morbidity and mortality that accompanies that. So it's just something to think about. If you're looking at someone and you don't think they're a great surgical candidate, maybe this is an option for them. Some SCS targets, we place the electrodes in certain places in order to target certain pain syndromes. If we want axial neck pain, occipital neuralgia, we'll put the electrodes in the dorsal column up to C2, the upper extremity anywhere from 2 to 5, the hand 5 to 6, low back T7 to T9, thigh and knee 9 and 10, and you go down until the thoracolumbar spine to get the foot. And just to give you an idea of why we're placing these where we place them. The other syndrome that I think spinal cord stimulators are a home run for, really truly one of the best treatments we have. And you will see some of these patients in your practice because they get misdiagnosed, or sometimes after our procedures, they develop this horrific neuropathic pain syndrome, which is complex regional pain syndrome. So it is a very debilitating, painful condition in a limb. There are sensory, motor, autonomic, skin, and bone abnormalities. The pain is the leading symptom, and it is disproportionate to the injury the patient had. It can be associated with limb dysfunction and disuse. It is a severe psychological stressor for these patients. This is a horrible, horrible disease. It is divided into 2 categories. CRPS1, where there's an absence of a nerve injury. And that used to be called reflex sympathetic dystrophy. It's incredibly rare. It is highly, highly rare. It's not confined to one nerve distribution. It's kind of diffuse. It is if you see it once in your practice, you will know it. You will see these patients with the skin changes, the swelling, the temperature changes, is the modeling of the skin, the color changes. It is highly striking. And in order to diagnose that, to consider a patient for a trial of any of the neuromodulation devices, there is something called the Budapest criteria, where you have to have a certain number of these categories, these changes, to document it in order to proceed with a trial for the patient. It's sort of what defines it as CRPS type 1. And again, most of you may not even encounter this in your practice. But what we see the most of is CRPS type 2. And so this is where there's a presence of a major nerve lesion or injury. There's causalgia. If you can name the nerve, it is CRPS type 2. And this would be, you've done a spine surgery and they develop horrific allodynia in the limb afterwards. You get imaging, you can't see anything specific, but it's in that L5 distribution. That's where you were operating. You would call that a causalgia. When the orthopedic surgeons, fix a fracture and they develop this horrific pain after the surgery that never goes away, that's a causalgia. That's CRPS type 2. And we don't need to fit the Budapest criteria to consider them for neuromodulation for that. So this was
Dr. Motivala, can I interrupt real quick?
100%.
Hi, how are you? It's Ali Bash from Phoenix. Thanks so much for these wonderful slides. Just one point and then a question. The point goes back to your prior cases of the spine surgeries.
Yeah.
And I think, I don't know what my other colleagues here but I completely agree with you in the sense that I've kind of shifted my idea on spinal cord stimulation in the sense that I'm with you completely. If I do a surgery and let's say the patient at some point needs a revision or doesn't do well, which of course happens, or if they're coming from somebody else and they need a major revision, I think in the old days, certainly when I was training, it was, well, let's do the big whack. And if they don't get better, the last resort is spinal cord stimulator. Yeah. And I think now, now in the last few years, I thought that just totally does not make sense. Probably because I have a lot of pain management friends and a lot of neurosurgery friends who do these, but I don't do them. I don't do, I don't do neuromodulation, but I've come 360, just like you've mentioned, which is why not try the less invasive procedure first? And I don't tell my patients it's a surgery. I say it's a procedure.
Yeah.
I say, why don't you try the pain relief? Well, that's great. If not, we can always do the revision surgery or the bigger operation. And I think I believe that's probably a paradigm shift with a lot of younger, at least neurospine surgeons. We have some colleagues here who are orthopedists. Yeah. I'm interested to see what they have to say in the chat box. But I think that's a very, very patient-centered mentality in which, technically we really want to do this technically gratifying revision surgery, but probably what's in the best interest of the patient. Hey, if they get better with a stimulator, that's probably better for them. So
that is, even further, if you as a surgeon are kind of on the fence about doing the surgery, you can always send them to your neuromodulation colleague in pain and neurosurgery and say, why don't we try this? The patient doesn't get excellent relief from that. You bring them back, you do your surgery that you had planned. There really is no loss to giving it a go, honestly.
Yeah, no, I agree with that completely. And then the second point, just regarding the complex regional pain syndrome slide, which it's a very tough, the one before, the type 1 and type 2. Yeah. Do you expect to see any EMG changes or electrodiagnostic changes with these? Because obviously we have our fair share of patients that may or may not be CRPS, post-op pain, et cetera. Does the EMG help in any way with these diagnoses or not really? And then I'll stop and
I'll be honest, for the most part, no. I mean, I have seen some of the worst types of CRPS and they have totally normal EMGs. And you can see it across the hall when they walk into the room. So I would not go on that. Really, it's, the clinical criteria, the diagnostic criteria. Again, it's kind of a diagnosis of exclusion. You want to exclude any other causative factor. But, one of the things I do see is it's clear it's CRPS, right? It has all the features of it, but the patient then goes get an EMG and they're like, oh, there's a little median neuropathy. Oh, for the upper hand, there's like a little ulnar neuropathy. They go and get these released by someone who doesn't understand that that's what this is, and it tracks. And so what started in the hand now is up where you did the ulnar nerve decompression, is now going up to the shoulder, and every time it's brutal. And it's hard for patients, and it's hard for doctors. I'm not, you're trying to help someone. They have some of the features of something you're seeing on, on EMG, clinically and otherwise, and you're just trying to help them. And, I think the biggest thing is to bring awareness to what it is. So once you recognize it, once you know it, right away, they want to get into PT right away. They want to get injections right away, but you do not want to wait years and years and years before you are going to do the trial, because then it can imprint centrally, and some of them, then it's completely refractory to everything, and that's really sad. Then you literally have like ketamine infusions and horrible narcotic pumps to offer them, and that's it. And even those don't help. And it's devastating to these people. It's truly devastating. And so I just wanted to show you a couple cases that, we have of that, and then lead us into sort of where the field is going, and talk a little bit, because we've been discussing just dorsal column stimulation, which is the mainstay. That's what we've had for decades, but we are starting to move past that. And I want to talk about that too. This is just your basic, this is a 37-year-old patient of mine. She got injured at work, and some heavy object fell on her neck and her left shoulder and arm. And she got this horrific allodynia in the hand, forearm, and separately axial neck pain. And she got a progressive claw deformity in the left hand from disuse, temperature differences, swelling, all of that. The skin got shiny. And she had cervical imaging, shoulder imaging, limb imaging, EMG, everything was within normal. And we were able to make this diagnosis of CRPS, more diffuse, CRPS type 1, because we couldn't find a specific injured nerve. And there was no surgery that she had had. And what we ended up doing was a percutaneous cervical stimulator system. We put the electrodes a little wide space up to C2 and covering. So we got down the neck and the hand with that, but also some of her axial neck pain. And over the course of the last year and a half, she has, with the stimulator on and aggressive physical therapy, gotten the use of her hand back, gotten some range of mobility in her neck and in the shoulder. And it's really pretty impressive how normal she looks now compared to before. She's back to working. It's that sort of stuff is gratifying. And this is a patient that some of us who do spine surgery are going to have. And this is where I wanted to show you a little bit of the dorsal root ganglion stimulators, and we'll lead into that. This is a 26-year-old patient who had a discectomy, I believe, a recurrence, and then ultimately had a 5-1 TLIF with a colleague of mine. Shortly after the surgery, that cage migrated back, and they had to go and do a revision. And subsequent to that, she just got this horrific allodynia of the top of the foot and the bottom of the left foot. Not a radiculopathy. It didn't start at the top and go down, just severe hyperesthetic pain. She couldn't wear a shoe. If the sheet touched her foot when she was sleeping, she would wake up screaming. You become phobic of contact with other people for fear someone brushes up against you. She was using a cane. She's 26 years old. She started, actually, her job was as a physical therapist. So this was really, really debilitating for her. She had a full year of treatment, nothing worked. And then we decided to do a trial and ultimately an implant of a dorsal root ganglion stimulator. And I want to talk a little bit about what those are. Some people have probably seen them, some have not, and what we're using them for. So right now, the dorsal root ganglion stimulator is only FDA approved for CRPS. And how it works is we are putting these tiny, very small, flexible electrodes out the neural foramen and laying them on the DRG at that level. So what we are able to provide is a very targeted stimulus versus dorsal column, where it's like filtering the superhighway. All of those nerve fibers are coming in. Some of them are deeper than others. And so to penetrate down to them, it's difficult to capture them. But with DRG, you are stimulating the atypical nerve directly in that dermatome. So very, very specific, very, more stable. And because there is very, very little CSF over the DRG, so the dorsal column, you're penetrating through that CSF to the back part of the cord, down deep into the cord fibers. You have to use a lot of energy for that. With the DRG stimulators, you use very, 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 very low amplitude energy, very, very low. And so these batteries, they don't have to be recharged. And some of the patients are working on like 15 years on the same battery. So that is very, very, very exciting. And again, it allows us to really target a specific neuron, allows us to not recruit other non-painful neurons. It really is a precise target. It's very predictable and it's very efficient. And for the CRPS patients, what we can then do, we have certain targets we want to hit. And in the case of this patient, typically for the foot, you want to target L5, top of foot, S1, bottom of foot. In our patient, I just want to go back and show you that there is some great variability and some flexibility with this. You know, we can't put anything out that 5 neuroforamen. I mean, it's been cast, she's been operated on there. There's scar tissue. Wouldn't be safe, wouldn't be dangerous, would be dangerous potentially. So we put it at L4. And why? Because we have found there's a certain amount of crosstalk with the DRGs, 1, maybe 2 levels. So, you know, if you are planning to target, let's say, an L3 and an L4 for the knee, if the patient's having intractable knee pain, and off-label, we're using some of this for post-joint replacement pain as a causalgia. You have a joint replacement surgery, you have chronic knee pain, you see multiple orthopedic surgeons, everything is fine. We are putting these in for that. And if we can't, for whatever reason, for anatomy, maybe they also have a spondylotic spine, and we can't get an electrode out L3, then we might go to L2 and L4 and sort of bracket the pain that way. And we've had a lot of success. This technology has a lot of potential applications, and you can target different pain syndromes out different foramen. We are getting excellent low back pain coverage with the T12. Groin, if they have that sort of femoral neuropathy or some weird groin pain they develop after your surgery that doesn't go away, we are able to target it at L1, L2. And I said like the thigh 2 and 3, the knee 3 and 4, and patients who have weird pelvic pains, chronic pelvic pains, this is some of the best pain treatment we've had. We putting stimulator leads at L2 and S2 and really able to help them with that. One of the things we're starting to see, and it is off label, as we're seeing some of our sort of more experienced DRG implanters putting in electrodes bilateral T12 and bilateral S1 foramen to cover for axial back and leg pain for failed back. So it's not FDA approved from that, but they are getting really, really, really great and durable results. And so that is very, very exciting. And so where are we going next with all of this? What are the next phases? You're going to hear a lot, or some of you may hear a lot about diabetic peripheral neuropathy. Inevitably, you're going to be sent patients for radiculopathy, and when you work them up, it's going to be peripheral neuropathy. It's going to be diabetic neuropathy. And what we are finding is we now have FDA indication for diabetic peripheral neuropathy with dorsal column stimulators. So if the patient can get their A1C below 8 and it's been reasonably well controlled, and they have horrific refractory neuropathic pain in the limb, and you have determined that there is no cause from the lumbar spine, then they are excellent candidates for this when everything else has failed. And the really big thing that is coming on the horizon, you know, Abbott is about to probably publish the results of their DISTINCT trial, is non-surgical back pain. So all those patients you see in the office who have horrific back pain, but you can't find any structural cause of it, right? It's kind of diffuse. The discs are good, the alignment is good. There's nothing you would do surgically. So you send them for PT, you send them for pain management. They might end up on narcotics, but we are now seeing with the burst waveform platform that that these patients can be treated with neuromodulation. So that is where we're headed next. And further down the road in early clinical trials is looking at DRG stimulation for inflammatory arthropathies. So can you treat OA in the joint before the patient ends up with a knee replacement? And there has been some really excited mouse modeling with that. It's still in its infancy, but these are sort of the things that we're starting to see, the extrapolation of these devices. And that's basically the kind of the journey till now.
Wonderful. Thanks so much. That was great. I will say this though, when it comes to the treatment or potentially neuromodulation for non-surgical back pain, I will say that I do, I do hope, and I'm sure that this will happen with our colleagues in, neurosurgery, definitely neurosurgery, hopefully also pain management, because a lot of this stuff is so industry driven, like it was for a long time and currently is with spine implants.
Yeah.
That there really is good evidence for it, and we just be cautious of the potential overutilization of these types of implants. I mean, unfortunately, sometimes to advance the field, that has to happen, so we learn from our mistakes.
I mean,
But can you comment on that?
100%. So this will be the problem with overutilization, and we certainly see it now. And one of the problems with spinal cord stimulators is it is subjective, right? We do a trial for 5 to 7 days, and our only metric is how do you feel, right? Was your pain better? Did you feel like you could walk better? How do you feel? That's it. On a score of 1 to 10, how was your pain, right? We have to change that, because inevitably we will end up implanting people who have a certain amount of wishful thinking, hopefulness when they feel hopeless, right? You want it to work so badly, you can convince yourself you felt better. There is a certain placebo effect to this, right? And so how do you select for that? It's a little tough, right? Because you don't want to discount the patient, but it's a little tough. So what I'm really excited about is the opportunities for data collection, real data collection. And part of that is a lot of these devices are now cloud-based, right? We can pull data from your battery, and that's expanding. So ideally, when you have a trial, battery is going to be able to sense, how far you walked in a day, like a pedometer, right? Like, get these patients, they do have them do a whole pre-testing. These patients now, a lot of, so Abbott's device, but a lot of them are moving where it's going on your cell phone, on your iPhone, right? So it hooks into that. So you'll be able to see how far they used to walk before. You'll be able to see, kind of what their daily activity base was, these Aura rings and things like that. How well did you sleep? All this stuff is like tracking our biometrics. And ideally, what you would want is to track the patient's biometrics before and during the trial, right? And then you would have some concrete, valid data of not just how do you feel, like, did it make you more functional, right? Because that's what we're aiming for, is make you, chronic pain makes you less functional. If you are out of pain, are you more functional? And so that's the sort of stuff we have to kind of push for as a field, because what will happen if we just put these in everybody, and there is a real, with sort of the field of pain, a lot of these doctors are opening their own surgical centers. They're becoming much more procedure based. We can sit here and talk about whether your pain management doctor should be a spine surgeon and all of these procedures they're doing at length. I'll be happy to come back because I live in the space. I see this space, they're like the cardiologists coming for us. That's what's happening. If we don't protect it and it gets put in, it will all get explanted. And if we have a very high rate of explant, then insurances will no longer cover what is a very useful and helpful device in the right patient. And that would be a real shame. So what I tell patients, if I'm sending for them for a trial, I say, look, there is a clinical specialist from the company attached to this trial. They're going to be calling you every day to see how you're doing, right? They're going to be really positive. I want you to ignore all of that, because I don't want to put this in you if it's not going to help you. So you have to just really sit there and think critically, because it's still a surgery once I implant it. Did this really help me? And, I try to be as honest with them. I try to tell them our goal is not 100% pain relief. There is no such thing. I'm just here to help you. And that's why we call it chronic pain. You are always going to have chronic pain. I'm just here to try to help you manage it better. And it's not going to be one thing. It's going to be a combination of things. And so those are the sort of ways I try to really help select the right patient, the right motivations. But it is tough. It is definitely tough.
Dr. Motivala, Mike Selby here from Australia. That's just a fantastic talk. I actually am an orthopedic spine surgeon who has quite a big, what I call my secret neuromodulation practice. It's not something I put out there too much, and I got a few comments, but we got a couple of regular contributors on the chat box who've asked a few questions. Is that okay if I
Absolutely,
fire
please.
these at you? Dr. Birchuk, who's regularly on Virtual Global Spine, is a fantastic contributor. He's got a couple of questions. One is, are the terms spinal cord stimulator, neuromodulation, and dorsal column stimulator all synonymous?
So neuromodulation refers to putting an electrode anywhere in the human body, anywhere in the nervous system to affect a change in the way the nervous system fires. So neuromodulation, the field encompasses deep brain stimulators, vagal nerve stimulators, neuropace for epilepsy, all of this where we are physically implanting electrodes to change you in some way. And that is the whole field. And the field is big and it's changing. But dorsal column or spinal cord stimulators. So spinal cord stimulators and dorsal column stimulators are also called classic stimulators. Those are the only ones we had forever. We put wires, in the epidural space on top of the dura, dorsally along the dorsal column. And so spinal cord stimulator, it's a little tricky. So spinal cord stimulators really technically refer to the dorsal column stimulators. Dorsal root ganglion stimulators are now their own pocket. And it is a very new place that we are placing them. Not totally. I'll be honest, some of the most creative people I know were putting the traditional spinal cord stim wires out the foramen. They weren't rated for it. It was off label. They were trialing all these things, and that's how they got the idea. And then they developed a product that is tiny enough to really accommodate the foramen without causing too much mass effect on it. That has a different issue with the fact that they have a higher fracture rate and a little bit of a higher migration rate because they are really, really delicate. But they do a wonderful job.
Excellent. Dr. Birch, I just had another question. When is a morphine pump indicated versus SCS? I think that's a great question.
Great question.
We've moved away from morphine pumps here a lot because of the effectiveness of SCS, but I suppose the question is, when would you consider one now?
So intrathecal pumps, as far as the narcotic pumps, we really try to avoid them. We really try to exhaust everything we can in structural spine and in the neuromodulation of space of spine before we put them in. It is, they are a lifetime commitment, right? And there's all sorts of downstream effects of them. They have can have a very high long-term complication rate. It's not like you put it in, you set it, it's good. These patients have to be meeting regularly with their pain management doctor. Every time they get filled, there's a risk or programmed a risk of something going wrong. If you reprogram them poorly, they'll get a massive dose of medication, they can die. If you under-program them, they'll go into horrific opioid withdrawal, which is like terrible, and end up in the hospital. They can get infected every time you are filling them. There's a lot of, and if they stall out, they go into withdrawal. All of these things, they're not for the faint of heart. They require a lot of commitment and dedication and support for the patient. And quite frankly, over time, you keep, just like any narcotic, you keep going up and up and up and up and the dosage, right? Change medication, something that's more concentrated, add another medication. So I really see that more as like you really have exhausted everything. We have a few patients, especially in degen spine, who've had these huge degen surgeries, failure, revision, extension. They get to the point where their whole spine is fused. They're miserable. Even then, we try to use neuromodulation. Like I have done sort of what a kind of an on table paddle trial. I'm sure somebody else on the talk has, where you just go, through all the fusion bone, do a laminectomy, the epidural space is still spared, and just put a paddle without trialing them because you can't get a needle in to trial them. So I've done that before I put in a pain pump, just to give you an idea. I'd rather do that than put in a pain pump. Because if that doesn't work, you still have the pain pump. Once you go to the pain pump, these patients are very hard to manage. If they get any further procedures, they're very hard to manage their postoperative pain. When they have that level of milliequivalence. Where I like the pain pumps is for cancer patients, for terminal stage cancer patients. Those that have several months to, year to live, who are in intractable pain. Those are the patients that I like the pain pumps for. I also like the intrathecal pumps for anyone with spasticity who needs baclofen. Okay, spinal cord injury patients, stroke patients. These are life-changing MS patients who are having a lot of spasms. Some of those patients will end up with both. an intrathecal baclofen pump and a spinal cord stimulator. They have both sort of axial kind of chronic back pain, but also limb pain, but also all the spasticity. So sometimes we have to put both of them in those patients. So those are the patients I feel good about putting pumps in. Just, you know, the narcotic pumps for just your run-of-the-mill chronic back pain, I really, really don't enjoy.
Yeah. Oh no, that is my thoughts exactly on a lot of those subjects. I mean, I think intrathecal pumps from a structural surgical perspective are a nightmare if we've ever got to go in there, and should be avoided. But yeah, I agree. The occasional cancer patient with multiple spinal lesions that they're not amenable to surgery, it may be a reasonable indication. Dr. Bass has a quick question. Actually, this is a really good one because I got a similar patient that I'm just thinking about at the moment. How would you neuromodulate pain due to arachnoiditis of the cauda equina?
So that is a very tough one. Okay. And again, you know, even the neuromodulation sometimes doesn't work for that. It's not a slam dunk. You know, depending on the distribution of their pain, if they're telling you that it's sort of just buttock down the legs to the bottom of the feet, more of like a sciatic type issue and less diffuse, I may consider doing a bilateral S1 DRG stimulator trial and really targeting it if that's where it is. If it's kind of like whole leg and a little more difficult, then I would try a dorsal column trial, assuming that whatever surgeries they have had would allow me to accomplish that, right? Because most of these patients have had spine surgery. You may or may not be able to trial them in the epidural space. That's why I like that S1 DRG, because most of the times, even if they've had multiple level laminectomy, you know, what we do for people out there who aren't doing this is you literally just stick the needle dead on down the S1 foramen, right? So you can avoid all the hardware. I've only had one patient, I wasn't able to get it in because her iliac bolts were like just on an angle covering the S1 foramen that I couldn't get the needle in a way that I could thread it properly. And you know what? I put it in at S2. Remember I said there was some redundancy, and I got her good relief. She just had pain in the buttock down the legs continuously. Very sick lady. This, you know, she got like 40% relief. She could walk to go get her mail. She was very happy, you know? So again, there are always some other option, but again, if it's very, very targeted pain and I can sort of attribute it to kind of one nerve root distribution or that S1 kind of distribution, that's what I would do. Otherwise, I would do a dorsal column trial for that.
Excellent. JR, are you there? No, that's okay. I think Matthew Birchak's got another question. Just can you use it on peripheral nerves? You know, I think you can. I've given it a go once or twice when others wouldn't, and it's actually worked quite well. But
so yeah. Yes, actually, and there are very specific devices for peripheral nerve stim, which I didn't include in this talk. And the newest ones are very interesting. It sort of takes this idea that you only need stimulation in the peripheral nerve for a couple of months to kind of reset the nerve, and that is adequate. So there's a couple of companies that are making them, and it's actually got a little external battery, and it like gets taped. The patient has it on for like 30, 40 days, takes it off, whatever. And you don't do a full implant. Everything is removed. And in some patients, if they get relief by then they'll get relief. You take it out and they still have relief for about a year or so. So this is kind of more novel. It's not something I've been doing. It's something I've seen with my pain colleagues. But yes, there have been plenty of people who have taken these electrodes and just, you know, using an ultrasound and just threading them along in the direction of the deranged nerve, burying the battery in an appropriate place based on whatever they're targeting. And that has been done for years. It's plus minus. Honestly, if I can capture it with the DRG stimulator, I think it's more robust. You know, you're laying it in that area. And I would probably try that first before I did PNS.
Excellent. Hey, I've got one more question from me, and I'm sorry, this could be a whole nother talk, right? Because I know this has been a fantastic overview going through, but I'm a bit concerned about some of the trial findings for axial back pain, both from the Medtronic DTM trial and even this Abbott trial, because to be quite honest, I did not see those results replicated in the real world. And I think you've got to really there's a real nuanced selection process to these axial back pain patients. And when we define axial back pain, there are patients who are fine at rest, are fine by and large, sitting in small distances, but who get real mechanical back pain with everything they do.
I mean, this has always been the
typical farmer. And
yeah.
those patients I found get no benefit from this at all.
Well, so this is all part of it, right? Because truth be told, when we look at what are my home run patients? What are the patients that are like easy? The ones I know I'm going to help. They're the neuropathic pain patients. They're the patients with nerve pain of some type, right? The mechanical pain, occasionally, maybe I get 50% relief on them with a stimulator. Yep. But then when we talk about some fusion surgeries for mechanical pain, we're still looking at 50% relief. So I don't know that it's a failure, but it's not excellent. It's not the thing that excites me the most. I honestly, the radicular pain, the refractory radicular pain patients, the refractory CRPS patients, those are the ones that I know I can help the most, right? Those are the ones
I'm using the Reactivate. I'm using the Reactivate device a bit for these patients.
Oh, I haven't used that yet. How's that going?
It's going really well. We're collecting all our data, but our real world results pretty much replicate their RCT data at the moment. So I'll report back. But
do you want to tell everybody online what the Reactivate device is? Because a lot of people probably have not heard of this.
It's effectively a form of peripheral neuromodulation. I suppose it's in that group, but you're implanting a battery that acts on two leads that stimulate the medial branch nerves to the multifidus at the L2-3 level, so just over the transverse process. So the leads are placed quite laterally in a safe position over the TP into the intertransverse membrane. And that level was chosen because it effectively has the most robust supply to the multi-innervated multifidus muscle, and it acts as internal rehabilitation. The patient has to activate it twice a day to try to get their multifidus working again. And there are some really relatively strict criteria about implanting the device. Results so far, like you say, nothing is 100%, but we've had about 70 to 80% clinical success so far with the device. It doesn't work straight away. So a bit, I know neuromodulation doesn't always work straight away, but we get a fair idea early on how patients are going. Whereas the Reactivate data suggests patients are improving up into a year and even out to 2 years post-implantation, suggesting a sort of a stabilization mechanical effect. But I think it's also got a little bit of neuromodulation effect as well, which is funny. And the exact mechanism of action of this device is still a little bit up in the air, but it seems to work. So that's another whole topic, I think, of conversation.
Definitely.
Yeah. All right. Is JR there or Ali there? Is anyone the other panel? Sorry, I've hijacked it. People.
No,
no, it's all good. That was fantastic.
Like we're having a conversation, just the two of us. We should do that later.
So unless there are any more questions, it's a little bit past 7. So thank you so much, Dr. Motivala. That was awesome. And I guess next week we will have our next speaker for Virtual Global Spine. I hope to see you all there. Have a great night.
Thank you, everybody. This was wonderful. Thanks for having me.
Thanks, everyone. I'll tell everyone on the socials what we're doing.
I will.